Do we have the first speaker, Abhishek Kumar Tripathi? So we are running late by 15 minutes, so I would request everyone to stick to time. At least, please don't exceed 3 minutes. Uh, Venya Sharma? Yeah, please come. All those of you who have not uploaded your presentation, you can just get it done quickly with the IT person.
I'll start, sir.
Yeah, please start.
Good afternoon, everyone. I'll be presenting my e-poster on not to miss neovascularization of iris, hoping to reduce acts of omission. So as we know, neovascular glaucoma is a sight-threatening condition which usually runs an aggressive course, and about one-third cases of neovascularization of iris progresses to neovascularization of angle, leading to NVG in 33% cases associated with CRVO and 33% in diabetic mellitus patient. So I present to you this case to emphasize on the importance of thorough clinical examination of patient with high risk of developing NVG. These were the materials and methods that were used. Informed consent was taken. A 60-year-old female presented to the OPD with complaints of gradual, painless, progressive diminution of vision of left eye since 2 months. She had already previously consulted 2 ophthalmologists and was diagnosed with left eye central retinal venous occlusion. She was a known case of diabetes mellitus since several years, and it was not under control, and her HbA1c was 12.5. Here, as you can see on the left side of the screen, the right eye just had immature cataract, whereas the left eye had blood vessels along the pupillary border, which was on gonioscopy then found out that the neovascularization was then extending to all 4 quadrants of the angle. She had RAPD in the left eye, grade 2, and along with that, her IOP was 34 mm of mercury. Here, the fundus examination of the right eye, as you can see, the right eye was completely normal, whereas the left eye showed a cupping of 0.8 CDR, and neovascularization of disc was present. There were hemorrhages in all 4 quadrants along with hard exudates and edema, and even the peripheral fundus had hemorrhages and hard exudates. So the provisional diagnosis was left eye ischemic central retinal venous occlusion with neovascularization of disc, of iris, of angle, progressing to neovascular glaucoma. She had immature cataract and uncontrolled type 2 diabetes mellitus. So how this patient was managed was, first there was a medicine consultation that was done to control her sugar levels, and then she underwent a total of 5 sessions of left eye panretinal photocoagulation. On the upper side of the screen, you can see post 2 sessions of PRP laser and 1 anti-VEGF injection was also given, and her neovascularization completely regressed, as you can see in the picture. After 3 sessions of PRP laser and 1 anti-VEGF injection. She was also started on anti-glaucoma drugs. So as you know, CRVO is one of the main causes of sudden painless vision loss in adults. And NVI then starts from the pupillary border and then extends to leading to neovascularization glaucoma. So the conclusion is every CRVO patient requires regular IOP monitoring and regular slit lamp examination. Early detection and prompt treatment of NVI is essential to prevent the progression to glaucoma. And missing critical findings is considered an act of omission, underscoring the importance of timely management. Thank you.
Was the carotid Doppler done for the case?
No, sir.
No, okay. See, the hemorrhages were very fresh, and usually if CRVO is going to cause like NVA or NVI, it takes some time.
Yes, sir.
It is advisable that you have to rule out even any coexisting OIS also. In
Yes,
such cases, if you are dealing with such fresh hemorrhages.
yes, sir.
And why the laser, like what was the exact process of laser done? You have written 5 sessions over 3 months.
Yes,
Generally in NVG, we go for very aggressive PRP as early as possible.
Yes, the patient was not very compliant in the sense that she was feeling a lot of pain, so that's why we couldn't
So
do.
over 3 months, it's a big time. And when was injection given?
So after 1 month, so after 3 sessions of.
That's too late, huh? Because in NVG, yeah, we have to inject immediately.
Yes.
Rather, you inject first if it's a very bad case. Within
Right.
2-3 days, NVA start regressing. Okay.
Right.
Okay. But we don't have much time for discussion. Next speaker. Do we have
Thank you.
like Abhishek Kumar Tripathi? Yeah.
Good afternoon, everyone. Today we are just having a look on endophthalmitis.
Please put the timer for 3 minutes. You're putting it for
Yeah.
4 minutes.
So I will be presenting on fulminant intraocular endophthalmitis post intravitreal injection, which is presented as prostate branch angiitis. As we all know, endophthalmitis is the inflammation of the inner coat of the eye with a reported incidence of 0.028 to 0.056%, which is a potentially blinding condition. And whenever the endop present within 4 days of surgery or intravitreal injection is considered as a fulminant infection, which is a serious ophthalmic emergency. So there is a case of 42-year-old female which came with us with right eye blurring of vision with floaters 2 weeks, and she has a comorbidity of hypertension and diabetes with keratoconus in left eye. BCVA was 6 in both eyes, scintillating reflex was present on retinoscopy, pressure ring was present on anterior segment, and applanation tonometry was normal. When we did the fundus examination, so we have seen inferior hemiretinal vein occlusion with multiple hemorrhages, which can be seen on optos image. And later on, we did SSOCT, which is suggestive of interretinal cystic spaces with retinal thinning. And then we planned for the injection ranibizumab, but she underwent the same injection in the elsewhere setup. Left eye fovea was totally compact. On the fourth post injection day, she came with fulminant with sudden pain with redness. So we diagnosed as a case of fulminant post intravitreal endoph with the vision of 612 with flare of 1 to 2 in anterior segment with conjunctival chemosis. And when we have done the fundus examination, so that was clearly suggestive of prostate branch angiitis. Here you can see some perivascular sheathing with exudates in the vitreous cavity inferiorly. So we labeled as that prostate branch angiitis like thing. So within 2 hours of presentation, we did vitrectomy along with the intraocular antibiotics. Vancomycin, ceftazidime, dexa was given, and sample was sent for microbiological examination, and it came positive for staph hemolyticus. And post-operatively, we kept on topical fortified vancomycin, prednisolone state with atropine drops. And in the meanwhile, in the subsequent days, we also have given 2 intravitreal injection, which was given under GA as well. She was had a kind of phobia for intravitreal injections. On day 4, vitreous exudates were noted. Some exudates were noted under the peripheral vitreous gel. We started with linezolid antibiotic, and continuously we monitored the blood counts. On post-op 6 weeks, so here you can see the optos image, all the hemorrhages were gone. There was a clearing of hemorrhages with exudates, and the fovea was compact on OCT. Prostate meningitis is a rare condition with fewer than 60 reported cases, and it consists of severe sheathing with local inflammatory process, and it looks like a frosted branches of a tree. Posterior segment findings were vitritis. There may be some visible things in the anterior segment in the form of AC flare. And so there are some risk factors for also endophthalmitis. It can be drug related, it can be injection related, can be patient related. Some common organisms which are found in endophthalmitis is coagulase negative organisms, and we got the Streptococcus hemolyticus. Thank you for the patient reading.
Okay. So very, very well managed case, I would say, and very brave on the part of surgeon to operate within 2 hours.
Yeah.
And how was the counseling done? Like patient agreed for the surgery
Yeah,
because
actually, the patient was had a phobia of. We asked for the injection only
Yeah.
initially, but she was not counseled on injection part. She wants to go for the operation part
Surgery.
only. So that we went for the vitrectomy and some not the rare organism, but we got hemolyticus as a.
Because usually the opposite happens that
Yeah.
doctor says go for surgery, they
Yeah.
want that no, treat me with injection.
True.
But I'm really happy to see such a good, well managed
Yeah.
case. Dr. Shishir, any comment?
Would you give DEXA in the first shot itself, or would you wait
as
for the
we-
result to come and then give a DEXA?
That can also be done if you have a good labs facility. We can wait on table. We can wait for for half an hour, and if we get some report on KOH, we can go directly on the basis of that also. But it was more of suspecting of not the fungal,
Yeah.
we are suspecting of bacterial, so we
Bacterial, yeah.
pushed the DEXA in that
Yeah.
patient.
Fine. Great,
Okay,
greatly
thank you.
managed. Thanks.
Thank you. Thank you.
Yeah. So now we have Dr. Sanjana, who will be presenting on rare case of optic disc pit with choroidal coloboma. Okay, can we have the next speaker? Is the next speaker ready?
इसमें इसमें होना था ना संजना हाँ
सर नेक्स्ट बोल दीजिए कोई
Dr. Priyansh Agrawal, hypermetropia masquerading myopic fundus.
आपका भी पीपीटी नहीं है इसमें आप पीपीटी लोड कराएं तो देख लीजिए प्रियांश अग्रवाल सर मैं स्टार्ट
Yeah, sure, go ahead.
Good afternoon, everybody. I'm presenting on hypermetropia masquerading myopic fundus. Hypermetropia is a quite common condition, quite common refractive error with decreased axial length of eyeball being the most common cause. And in myopia, there is increased length of eyeball with the image focusing in front of retina. There are various fundus changes in myopia like discolor, temporal crescent, tessellation, atrophy, lacquer cracks, fossifix spots, lattice degeneration, CNVM, PVD, and posterior cephaloma. Aim of the study aim of the case series was that 4 cases were reported on dilated fundus examination which showed myopic changes in fundus, but the final refraction after PMT came out to be hypermetropic. So it is a case series of 4 cases, with all cases between the 55 to 70 years of age, out of which three were male and one was female. All presented with the diminution of vision, and there is no history of trauma or any insignificant history in all the cases. In first case, the uncorrected visual acuity in right eye was 660, which was correcting till 636 on pinhole, with left eye being finger counting 3 feet and no improvement on pinhole. BCVA was 6 by 24 partial with plus 0.5 diopter cylinder at 180 degree, and finger counting 3 feet with plus 0.5 diopter at 180 degrees in left eye. Axial length was 25.0 and 24.8 millimeter in both the eyes. In second case, the uncorrected visual acuity was 5 by 60 and 6 by 60 in the left eye. 624 with pinhole and left eye correcting to 618 partial. DC was 6 by 18 with plus 1 diopter spare and 0.75 DC at 185 at 150 degrees. 6 partial was noted in the left eye BCVA with with hypermetropic correction. Case 3 was almost similar refraction. On anterior segment examination was normal in all the 4 cases. Just the lenticular changes were present. On slit lamp examination, IMSC in first case.
You need to wrap up fast, huh?
Yes, yes, sir. Just 2 minutes. Pseudophakia in third case, and early lenticular changes in the final case. In fourth case, there were myopic fundus changes in all the cases, like tilted disc and CNVM in the first case. and tessellation and CR atrophy were present in all the cases.
Come to the conclusion. Yeah, come to the conclusion.
Phosphofuchs spots in the final case. Now these are the OCTs, and the conclusion is with intricate landscape of ocular health, hypermetropia emerges not only as the common refractive error but is also a potential veil for su- uh, sub, subtle myopic fundus pathologies, and hence all the patients with BCVA showing the hypermetropia not improving to vision of 6/9 or better must be dilated for the detailed fundus examination.
See, I have gone through your e-poster before. There are some gross errors in that. Okay. First thing is your third case is pseudophakic both eyes. See, if a high myop minus 20 diopter gets a phakic IOL done today, will you and if there's an overcorrection and gets +1, will you consider it as a hypermetro with myopic features? You won't. It's a pseudophakic case.
Yes,
It's most of a biometry error. Okay, all your cases are old age patients with lenticular changes. They are not having 6/6 vision. They have cataractus changes. It's a lenticular change which is causing. You see the actual length of all your cases. They are 24, 25.
24, 25.
So they are myopics who have not worn glass. They are having cataract now, and because of the lenticular changes, there is a lenticular myopia getting induced. And what is the power? It's +1, +0.5, something like that. And third case is absolute blunder. You can't tell a pseudophakic patient to what is the aim. If you get a myopic cataractus patient, what will be your aim? To bring emetropia 0, right? And say if it fails and if there is +1 error, that's a biometric calculation error. You can't tell that that patient is hypermetropic having myopic features.
Yes,
Okay.
Sir, actually the case series was reported because there were there were two basic patients, like the second case with the clear lens and the fourth.
No, if it is clear lens, what is the reason for vision not being 6/6? Your vision, you have mentioned, vision is not 6/6.
Sir, because the foveal reflex was poor and.
But that does not amount to 6/24/18 vision.
Yes, sir. But
Lenticular changes have been missed most likely. Okay. Yeah.
okay. Thank you, sir.
Yeah. Dr. Sanjana, are you ready?
Good afternoon. My name is Dr. P. Sanjana. Today I am presenting a rare case of optic disc pit foveal with choroidal coloboma. Coming to the introduction, congenital optic disc pit is observed as a round or oval, grey, white or yellowish depression in the optic disc. Congenital optic disc pits commonly involve the temporal optic disc but may be situated in any sector. Histologically, optic disc pits consist of herniations of dysplastic retina into a collagen-lined pocket extending posteriorly, often into subarachnoid space, through a defect in the lamina cribrosa. Optic disc pits are usually unilateral and sporadic in occurrence. Chorioretinal coloboma is characterized by a congenital absence of a part of the retinal pigment epithelium and choroid caused by defective closure in the embryonic fissure. Coming to the case history, a 6-year-old female child came to the ophthalmology OPD with a chief complaints of diminution of vision in both eyes. On examination, her best corrected visual acuity was 6/9 in right eye and 6/6 in the left eye. Anterior segment examination reveals normal findings. Fundus examination of the right eye revealed a large coloboma inferior to the optic disc, not involving the optic disc or macula, and also a grayish white small hypopigmented depression present in the temporal part of the optic disc, suggestive of the optic disc pit, and the macula was normal. Left eye fundus examination reveals normal findings. Coming to the figure A, we can see the retinochoroidal coloboma with laser photocoagulation along the border of the coloboma. And in the figure B, we can see right eye fundus showing photocoagulation marks around the optic disc pit. Left eye fundus reveals normal fundal changes. Prophylactic treatment and follow-up. Prophylactic laser photocoagulation was done along the temporal border of the optic disc and along the borders of the choroidal coloboma to prevent the serous detachment of the macula and extracolobomatous retinal detachment, respectively. Optic disc pit cases may be asymptomatic, and it is estimated that up to 2/3 of the patients develop visual problems due to the progressive accumulation of the subretinal or intraretinal fluid, causing serous macular detachment known as optic disc pit maculopathy. Visual loss due to optic disc maculopathy can be irreversible if left untreated. Laser photocoagulation at temporal disc margin has been proposed as a treatment for optic disc pit maculopathy, with the reasoning that laser scars will create a chorioretinal adhesion which will act as a barrier between the optic disc pit and subretinal space. Generally, the patient with retinochoroidal coloboma are too young to sufficiently explain the visual changes. So most of the patients present with long-standing retinal detachments with macular involvement. Prophylactic laser photocoagulation is recommended along the coloboma margin to create a strong chorioretinal adhesion and reinforcing margins. By this way, it provides a significant benefit for reducing the risk of extracolobomatous retinal detachment. Coming to the conclusion, an early diagnosis can help in preventing the vision-threatening complications through regular follow-up and prophylactic treatment. Thank you, sir.
Yeah, thank you. So have you done a literature search? Have you done a literature search on how many pits have presented with coloboma also
Until now, 7 have been reported, sir.
in literature?
Yes, sir.
Okay.
And do you routinely do that laser photocoagulation for any OD pit?
So generally, the cases which present with maculopathy, we do, sir. But
No, without maculopathy. That's what I'm saying. Cases without like this patient was
prophylactically it
lasered
happens,
by.
sir.
It was done by your institute,
Yes,
the
sir.
laser.
Yeah.
Because I don't know, Dr. Shishi, do you proclaim? Because I don't think it's very popular in today's date when you have such good surgical possibilities. There was a time when surgical option was not available. So that in that era, people used to do laser photocoagulation. Now you can easily wait. Papillomacula bundle, you're doing laser. So now you can easily wait. Many patients will not have any maculopathy. The ones who have, you can nicely do a surgery, go and do ILM flap, or you can put a scleral patch. I don't think it's a very wise decision to laser these cases as such. And for even for coloboma, unless there is ICM detachment, I think it's not very wise to go and barrage all coloboma cases. Okay. Do we have the next speaker, Mr. Dr. Kalpesh Patel? Yeah. Can you please proceed?
Good afternoon. I'm going to talk about correlative study between macular thickness and visual acuity in patients with diabetic retinopathy. Diabetes mellitus is a major systemic cause of blindness in major part of the world. Diabetic retinopathy remains a significant cause of acquired vision loss in working age group worldwide. This study was to study the correlation between mean macular thickness with distance and near visual acuity with optical coherence tomography in patients with diabetic retinopathy. It was done in tertiary care hospital. The duration was 1.5 years. 216 patients were included in my study. It was a cross-sectional study. In the study, the patients with diabetic retinopathy with CSME were included, and the patients with lenticular opacity or in whom posterior segment examination cannot be done were excluded from the study. The distance visual acuity was done measured using Snellen's chart, and near vision was done using Jaeger's chart. Fundus examination was done using indirect ophthalmoscopy and slit lamp microscopy using 90D lens. Grading of diabetic retinopathy was done using ETDRS grading. These were my results. Female and male patients were equal in number. Logmar distance visual acuity was mean of 0.456, and for near it was mean of 0.408. The macular thickness ranged from 160 to 480 micrometer. A linear correlation was established between OCT measured mean macular thickness for both distance and near vision. The correlation varied from 0.46 to 0.9, indicating the moderate to good correlation. In our study, correlative efficient was 0.926 for distance and 0.899 for near. This means there was good relationship between visual acuity for a given level of macular thickness. Although in our study the correlation value is high, we found the range of visual acuity for a range of macular thickness. For each 100 micron change in macular thickness, best corrected visual acuity showed 0.3 logmar unit change for distance as well as near. The limitation of the study was it was an institutional based study. Diabetic patient only with diabetic retinopathy with CSME were included in this study. To conclude, macular thickness and visual acuity has strong correlation, but there are some variations in the finding. For a given degree of macular edema, there is wide range of visual acuity is possible. Even though macular thickness is a strong predictor of visual acuity, many other factors also play a role in determining visual acuity for a given patient. Thank you.
Yeah, thank you, Dr. Priyansh. So So it's already known that, central macular thickness has a variation with the visual acuity. But that was the first biomarker. So did you look into any other biomarkers? Subfoveal fluid, presence of hard exudates at the macula. Any other biomarkers did you look for? Because all of them can vary with the cause of variance in the visual acuity.
Variance in the visual acuity was established, but there was not a linear correlation with other markers, sir. That highly variable results of visual acuity was identified with subfoveal fluid or any.
Yeah, because other parameters can also be there. There could be ischemia, there could be intracystic hyperreflective material. Other biomarkers also play a role.
No, because anyways, if you are doing a study, like it's a very expected outcome and everybody knows it. There are some other factors which you could have evaluated, like some 2-3 factors you search literature which on which studies haven't been done, and that you do, because if you're putting in so much efforts, at least something additional to what is already existing in literature is better if you can contribute. Okay.
Thank you, sir.
Yeah. Next, can we have Dr. Preeti Karn? Not uploaded. Okay. Do we have Dr. B. Vadava Krishnan?
Good afternoon. I am going to talk about the rupture of retinal artery macroaneurysm following thrombolysis leading to intraocular hemorrhage. He received an emergency call over from the cardiac ICU regarding the patient with sudden loss of vision following thrombolysis. 39-year-old male brought to EMD with sudden onset of chest pain since few hours. ECG shows anterior-inferior wall MI, hence promote thrombolysis using rectiplace was initiated. After thrombolysis, while in recovery, notice sudden painless loss of vision over left eye. We started as a few reddish floater and progressed to complete obscuration of vision. The patient is a known case of chronic kidney disease and uncontrolled systemic hypertension for 5 years. The BP was 240/160 mmHg and pulses 82 beats per minute. On examination, the visual acuity of right eye is about 6/12 and left eye is about hand movements. Anterior segment of both eye found to be normal. The posterior segment of right eye was media is clear, disc margins are defined, 0.3% cupping, arteriolation present, and AV ratio of 1:3. Multiple phase hemorrhage over the posterior pole and cotton pool spots are seen. This suggests your moderate hypertensive retinopathy. In left eye, the reddish glow is present and dense sapphire-like hemorrhage over the posterior pole, obscuring the details of disc, macula, vessel, along with vitreous hemorrhage seen. The patient was kept on head-end elevation and constant observation. The heparin was discontinued to avoid the increase of hemorrhage, and coronary artery angiography was deferred in the view of worsening hemorrhage. After 1 week, visual acuity improved to 6/60 and intraocular hemorrhage was decreasing. Posterior pole was visible, revealing dark reddish flake-like lesion measuring 1 disc diameter over supratemporal arcade with surrounding succinate exudates. Above finding, we conclude that intraocular was likely to be ruptured retinal artery macroaneurysm. Our patient received intravenous retivase, which is a tissue recombinant plasminogen activator. Since the patient has no visual deficit or radiologic evidence of intraocular hemorrhage prior to admission, this complication activates use of tissue plasminogen activator. The risk of hemorrhage complication associated with retivase is higher than the streptokinase. The potential benefit outweighs the risk, while intraocular hemorrhage complications are rare. The patient with a history of ophthalmic disorder should be advised about the ocular risk of this treatment. Tissue plasminogen activator is used to dissolve the blood clot in certain conditions like stroke, heart, and pulmonary embolism. The side effects are intracranial bleeding, GIT bleeding, and respiratory bleeding. While it is safe and effective, there have been reports of tissue plasminogen activator cause intraocular hemorrhage, like central retinal vein, diabetic retinopathy, and recent eye surgery also risk factor for this mentioned in this literature. Intraocular hemorrhage due to tissue plasminogen activator in acute ischemic stroke have been previously reported, but intraocular hemorrhage due to rupture of retinal artery macroaneurysm following thrombolysis have not been reported previously to the best of our knowledge. These are the references. Thank you, sir.
See, the point is, just go to the previous slide. Oh, it's not there. Okay, anyways. You want to say that the previous reports are not reported about RTPA causing rupture of macroaneurysm. But what is your hypothesis? How is it going to cause rupture? See, if I say that the BP was 240/160, that is the reason behind rupture of RAM, which was pre-existing in a hypertensive patient. If two things happen simultaneously, someone is having a bad systemic control, they have a myocardial ischemia, and they also have a ruptured RAM because of high BP. 240/160 is a very high BP. Because I don't know what are you postulating? Like, how can it rupture the RAM? That's why it's not reported previously. RAM rupture is most likely because of high BP, which was there in this patient. Okay. Yes, after getting ruptured, it will not get controlled well or contained well, and yes, fulminant vitreous hemorrhage that you can attribute to thrombolysis. Okay. Yeah. Dr. Preeti, are you ready? No. Okay, Dr. Preeti is ready. I think Dr. Preeti, you have not followed the AIOS guidelines for e-poster. So this is something we have to be. You'll have to zoom it, but then you were expected to prepare 12 slides and show it. You can just quickly go through it.
A very good afternoon to everyone. My poster is on a case report on retinal capillary hemangioma. Retinal capillary hemangioma is a benign retinal hematoma that may be associated with von Hippel-Lindau disease. It occurs in two forms, juxtapapillary and peripapillary lesion. VHL gene is a classic tumor suppressor gene located on short arm of chromosome number 3. Deficiency of VHL protein leads to accumulation of hypoxia-inducible factor, and it stimulates gene responsive for vascular changes, which will lead to proliferation of endothelial and stromal cells, and eventually it will lead to hemangioma. In my case, a 20-year-old patient came with complaint of right eye diminution of vision for last 1 year, which was insidious in onset, gradually progressing and painless. Uncorrected visual acuity of right eye was finger count 1 feet, and best corrected visual acuity was finger count 1 feet. On right eye fundus examination, fundus showed multiple capillary aneurysm, severe tortuous and dilated blood vessels, hard exudates with vitreous hemorrhage. On OCT, we found macular edema. On doing DFA, in early phase of DFA, venous tortuosity and hyperfluorescence noted in the venous veins. In late phase, focal leakage noted from the aneurysm. In management of this case, we have given posterior subtenant triamcinolone acetonide injection given to this patient in right eye, and post injection the report is like this. In left eye, laser photocoagulation of aneurysm was done. The latest management development, we can use intravitreal anti-VEGF injection, and oral propranolol can be used. Genetic counseling is very important in this patient. Chorionic villus sampling can be done in 10 to 11 weeks of gestation. Thank you. So this was a case of both eye isolated retinal capillary hemangioma. Thank you, sir.
Did you try oral propranolol in your case? No,
No, sir.
no, but it doesn't really work that well commonly. Please take care from next year. Like whenever you're coming up, if it's selected, you have to follow the guideline. Okay. And for your other treatment modalities like cryotherapy, and you have TTT, you have PDT. There are options which are available, especially for juxtapapillary. You don't have much options, but PDT has been reported, although it can cause optic atrophy. So these are bad cases. Often they don't have good prognosis. Right eye, you need to follow up closely. Even surgical management may be required after one point of time. Okay. VHL, you said that all tests were negative.
Yes, sir.
Yeah.
VHL. Okay, sir. Thank you, sir.
Next, do we have Dr. Banerjee, Dr. Lanjita Banerjee? Then can we have Dr. Muhammad Arif Mansoor?
Good afternoon, respected. Today, the topic of my presentation is enhancing vision restoration in laser-assisted sclerophysated intraocular lens implantation. And the laser-assisted SFIL is a novel way of a technique for innovating the insufficient capillary support. The aim of our study is to assess the feasibility, safety, and visual outcomes of this innovative technique. These are the materials that we use in this technique, that is 26 gauge needle and 3-piece intraocular lens, McPherson forceps and microforceps for maneuvering in the EC, and green laser probe for the appropriate bulb preparation. And it is a retrospective review, and Partsman vitrectomy lensectomy was done, and a lens fixated was performed using modify mani technique, which introduced using 26 gauge needle for externalizing the IOL haptics and creating a bulb at the end of the haptic using green laser, fixing the haptic in scleral fixated tracks, and clinical data was analyzed in this patient. And first we create a tunnel and extracting the haptic in the using this 26 gauge needle, and preparing the bulb by green laser, like shown in here. Creating the bulb precisely by the green laser, and fixing the scleral fixated attacks by help of the McPherson forceps. The patients are total of 15 patients were taken, and most of them are posterior dislocation of lens. And these are our results of preoperative BCVA and postoperative BCVA, and they are log mark. And astigmatism error was minimized, like complication was significantly reduced, and minimal astigmatic error. And precision is this is a discussion between green laser and ballpoint pottery, and most of this scanning is less, tissue damage is less in the green laser, and versatility and availability is usually more in ballpoint pottery, but green laser is available with most of the posterior surgeons. And in conclusion, it is to the best of my knowledge, it is first report of LSFRL, and a visual and effective solution for the intraocular capsular support, and it is an accurate and safe method, and it has enhanced visual outcomes. Thank you.
Thank you, Dr. Arif. I just wanted to ask you, what gauge of green laser? 25, 23?
Sir, I usually 25, 23.
Because the smaller the gauge,
Smaller,
then
yes,
the
sir, yes, sir.
amount of
Yes,
this
sir.
thing. And what is the power which you
Power
keep?
300, 300. I mean, with 200 milli per second.
Okay. And on follow-up, has anybody reported this issue of
No, sir.
foreign body sensation because you're creating a flange?
Yes, sir, yes, sir. We just push the bulb in the scale fixed tracks so that it is not
On the ocular surface,
yes,
it's not
sir.
irritating. Okay.
The outcomes are pretty good, and
Yes, sir.
you need to follow up the cases long term
Yes,
also.
sir, long-term follow-up.
Yes,
should be
yes.
needed.
Okay. Next, do we have Dr. Chitra N. Chitra? Yeah. She'll be presenting on enhanced S cone syndrome.
Good morning, one and all present here. My case is on enhanced S-cone syndrome. 15-year-old boy came to us with complaints of defective vision in both eye, and especially at night. And he is a second-born child of second-degree consanguineous marriage. He had on ocular examination, he had a right convergent squint to alternate convergent squint, and the visual acuity in right eye is 3/60 with plus 6D sphere and plus 1D cylinder. It improving to 636, and left eye 618 improving to 69. And color vision in both eye normal, anterior segment absolutely normal. And in fundus, we found out pigmentary changes noted along the arcades and in the posterior pole, and the macular foveal reflex was absent. Then we go with the macular OCT macula, on which the central foveal thickness is raised and foveal size is noted. The field shows the peripheral field defects are there, and we ordered a ERG, and fulfill ERG. It shows a it's absolutely normal. It shows a normal scotopic and photopic response, but but the S-cone, the separate S-cone, L-cone and M-cone ERGs shows the S-cone ERG shows supernormal amplitudes, and the L-cone and M-cone ERG shows reduced amplitudes, which is a pathognomic finding, confirmatory for this Escon syndrome. It's suggestive of enhanced Escon syndrome. And enhanced Escon syndrome is a progressive autosomal recessive retinal degeneration. It is caused by a mutation in NR2E3 gene, which results in gain of function in Escons. It typically presents in childhood with nyctalopia, refractive accommodative esotropia, decreased visual acuity, and hemerolopia. And the characteristic finding in fundus are nimilar pigmentary changes along the vascular arcades, and the diagnosis is confirmed by pathognomic findings on the ERG. It can be confirmed by genetic testings. And to elicit Escon response, we using a blue wavelength is given on a orange background. This is to suppress the red and green cones. So this will produce the Escon responses. In our case, the Escon response is greater than normal. The conclusion, this case has presented for its rarity. The prevalence of night blindness worldwide is around 1.2%, but a high index suspicion is necessary to think about these less common entities associated with nyctalopia. Moreover, a regular full field ERG may turn out to be normal. A discussion between a clinician and investigation is necessary to order a specific S-cone, L-cone, and M-cone ERG to reveal this kind of this enhanced Escon syndrome.
Yeah, very well presented case. The last point is very important, discussion between clinician and investigator, because often these are done under GA, general anesthesia, and if full field ERG comes normal and if Escon was not specifically checked, the patient will unnecessarily have to undergo GA again. So such cases, whenever there is an index of suspicion, it has to be planned well in advance.
Yes, sir.
But good case.
Yes, sir. Thank you, sir. Thank you all.
Next, we have Dr. Janani. She has another rare case, Moya Moya, and it's ophthalmic odyssey for us.
Good morning, one and all present. Today, my focus is on Through the Looking Glass, Moya Moya and its ophthalmic odyssey. A 12-year-old female child came to the OPD with the complaints of diminished vision in right eye for the past 4 weeks. Past history of weakness in left upper and lower limb 7 years ago, following which she was diagnosed as Moya Moya disease, neurofibromatosis 1. After regular follow-up, bypass graft surgery done between middle cerebral artery and superficial temporal artery was done 3 years back, and patient general condition improved. History of neurofibromatosis 1 was diagnosed 7 years back. Family history of neurofibromatosis 1 present in family, paternal inheritance. On general examination, neurofibromas 2 to 3 in number present on the dorsal part of the body as you see. The other general examination was normal. Investigation post bypass graft surgery was done. CT cerebral angiogram suggestive of right common carotid artery, external carotid artery, and internal carotid artery narrowed in caliber compared to left side. Multiple collaterals in right basal ganglia, cortical atrophy with encephalomyelitic changes in right frontal lobe. MRI angiogram suggestive of right middle cerebral artery, cavernous part of internal carotid artery, thinned out with extensive collaterals as you see here. So the ocular examination on right eye, visual acuity was 636, non-improving to glass and non-improving to pinhole, otherwise normal. The left eye 612 with pinhole improving to 66. On the left eye, the iris Lisch nodules were noted. So this comes to the conclusion that neurofibromatosis 1 was major cause, major manifestation associated with Moya Moya disease. The fundus examination on the right eye suggestive of shifting of vessels in inferotemporal carcate with extensive collaterals between superior and inferior arcade. Suggestive of right eye old vascular occlusion with extensive collaterals as you see here. So left eye the fundus was normal. Fundus fluorescent angiography suggestive of right eye late phase patchy filling of choroidal and retinal vessels with capillary non-perfusion over the temporal part of fovea. Extensive collaterals over superior inferior arcade seen suggestive of ischemic changes with extensive collaterals pairing the vision. Here there is the extensive collaterals which supply the macula pairing the vision loss. So my diagnosis is Moya Moya disease. Management selected targeted retinal photocoagulation is planned for capillary non-perfusion area. Patient is currently on periodic follow-up. Discussion. Moya disease is a rare progressive cerebral vascular disorder affecting the terminal portions of internal carotid artery or proximal portions of anterior and middle cerebral artery situated in basal ganglia. The term moya is a Japanese word which means puff of smoke appearance used to describe the abnormal appearance of vascular network due to collateral formation. Incidence of moya disease is 0.54 per 1 lakh in Japanese population. There is the only sporadic case reported and the exact incidence of moya disease is in India in unknown. When moya disease is associated with underlying conditions such as neurofibromatous but it is known as moya syndrome. The estimated incidence is 1 new case per 1 million individual per year. The ocular manifestations is amaurosis, phalanx, central retinal artery occlusion, monoglory syndrome and ocular ischemic syndrome. My summary is, although moya disease is a rare condition, it is important for the ophthalmologist to be aware of the ocular manifestations as they can lead to severe vision loss. Appropriate management of the disease required collaboration between the ophthalmologist, neurologist, vascular surgeon and primary care physician. Thank you.
Very nice case, rare case, and I think the distribution of CNP areas is something which should raise the high index of suspicion for something beyond RVO or RAO because it doesn't follow the proper distribution of blood vessels of retinal vasculature. Something like SLE, something like your moya is something we have to suspect based on the FFA. And I think it's moya syndrome. Your case is not disease. You have mentioned in diagnosis disease. You have only mentioned if both are coexisting, it's moya syndrome. Okay. So I think Dr. Shishir has to leave. He has to go and receive his award. Many congratulations, Dr. Shishir. Yeah. So next, would listen to Dr. Sunanda Kumari. Are you here? Yeah.
Good afternoon, everyone. This is a case report of retinitis and vasculitis with coats-like reaction, a diagnostic dilemma. The retinitis can be infectious or non-infectious. Infectious causes include viral, for example, HSV, VZV, CMV, fungal and parasitic. Non-infectious causes include post-fever immune-mediated retinitis. Then the patient was a 47-year-old female, presented with 20-day history of pain, redness, photophobia and diminution of vision in left eye. She does not have any history of similar episode in past, trauma or surgery to left eye. There was no other relevant medical history. Her best corrected visual acuity was 660 and pupil was sluggish reaction. Anterior segment examination shows there was very fine KPs present inferiorly over the corneal endothelium. There was pigments present over anterior lens capsule and posterior synechia was present from 9 o'clock to 1 o'clock. On fundus photography, there was vitritis. There was a mass of whitish fluffy lesion of about 3 disc diameter in inferior-temporal quadrant, and surrounding it there was coats-like reaction and vasculitis was also there. On OCT, it shows macular edema with subretinal fluid. Till now, our morphological diagnosis was retinitis with adjacent vasculitis with coats-like reaction and vitritis. Differentials include viral retinitis, fungal endogenous endophthalmitis, post-fever retinitis, and toxoplasmic retinochoroiditis. Then patient undergone diagnostic PPV where pan-fungal PCR was negative, fungal culture was negative, and PCR was also negative for VZV, HSV, and cytomegalovirus. Then patient undergone treatment cotrimoxazole 2 times for 6 weeks. Then lesion size regresses from 3 disc diameter to 1.5 disc diameter after 15 days, leaving retinal scar. This is fundus photography after 6 weeks where it shows healed retinitis with retinochoroiditis scar and vitritis. This case presented with both typical and atypical feature of ocular toxoplasmosis. Atypical presentation in this case were coats-like reaction and extensive vasculitis. A study done by Eli Teplitsky et al. Where some patients of exudative coats retinitis having toxoplasma as etiological factor. Frizotti et al. Also reported a case of parasitologically proved toxoplasmic coats retinitis. Ocular toxoplasmic feature can present at coats retinopathy as atypical finding. Conclusion: ocular toxoplasmosis can present with coats-like reaction as in this case. Toxoplasma retinitis are essentially clinical diagnosis, but additional investigation may be needed to rule out other etiologies. Ocular toxoplasmosis does not need immunosuppression to occur, and it is most common cause of posterior uveitis in immunocompetent patient. These are my references.
Fine. You mentioned something about laser treatment also in your
Yes, sir.
case. When was the laser done?
Sir, laser was done after biopsy was taken. It was actually prophylactic laser to for retinal detachment, to prevent retinal detachment.
Okay. Because doing a laser around inflamed retina is also a very dangerous thing. But luckily, I think spots were not very dense spots, so it was fine. Otherwise, doing laser on any inflamed retina is something which is not commonly recommended,
Yes.
because that itself will develop breaks. Okay.
Thank
Next, do we have Dr. Abhisha?
Good afternoon all. Today I'm going to talk about Hermansky-Pudlak syndrome, fundus a Pandora box. A 9-year-old boy came with presenting complaints of defective vision in both eyes since childhood. History of night blindness also present. History of wearing spectacles for the past 5 years. No history of similar complaints in the family. On head-to-toe examination, there was premature graying of hair. Systemic examination was normal. On ocular examination, bilateral nystagmus was present, UM was full. Visual acuity in both eyes was 624, not improving with glasses and pinhole. Intraocular pressure was normal. In anterior segment in both eyes, heterochromia iridis was present, otherwise the anterior segment was quiet. In fundus, the media was clear, disc was normal. There was hypopigmented fundus with prominent retinal and choroidal vessels present in the periphery. This is the fundus picture. You can see the prominent choroidal vessels which is present in the periphery. In investigations, we were able to do normal routine investigations which was found to be normal, and since the patient was having nystagmus, OCT macula was not able to be taken. In genetic analysis, we were able to find out the patient was diagnosed with homozygous for likely pathogenic variant in Hermansky-Pudlak syndrome type 5 gene, which is associated with Hermansky-Pudlak syndrome. Discussion. Hermansky-Pudlak syndrome is a rare autosomal recessive disorder affecting in 1 in 5 lakh population. It occurs due to mutation 10 following genes. The genes code for lysosomal related organelles which are found in melanocytes, platelets and lung cells. Mutation in one of the above gene causes oculocutaneous albinism, bleeding diathesis, pulmonary fibrosis. Here, the ocular manifestations are impaired vision, nystagmus, strabismus and iris translumination defects. Conclusion, this case was presented due to its rarity. It was due to the detailed fundus examination and clinical acumen that it was possible to diagnose the child at early such age. The child was advised observational routine follow-up in ophthalmological OPD. Since Hermansky-Pudlak syndrome has been known to cause pulmonary fibrosis and significant increase in mortality by middle age, our early diagnosis and routine follow-up in respective departments will provide many more productive life years for the child. Thank you.
Can we prevent the pulmonary fibrosis in such case with any prophylactic treatment? Like,
as of now, there's no prevention, sir, but luckily this patient has type 5, which has low incidence in pulmonary fibrosis.
we can basically prognosticate.
Yes,
That's
sir.
it. And whole exome sequencing was done for this case?
Yes, sir. Full
okay.
genome sequencing.
Full genome sequencing. Okay.
Thank you, sir.
That's the beauty of full genome sequencing. Like, we can come to know about such rare cases with that. Next, do we have Dr. S. Pujita? Yeah.
Good afternoon, everyone. I'll be presenting on the role of OCT biomarker.
Can we see the slides?
Good afternoon, everyone. I'll be presenting on the role of OCT biomarkers and systemic inflammatory index in type 2 diabetes. Diabetic retinopathy, as we all know, is a microangiopathic complication of diabetes with a prevalence of about 26.2%. It's the leading cause of blindness and visual impairment, especially among the working age group adult. The persistent hyperglycemia and oxidative stress leads to common chronic inflammatory response and sequential breakdown of the blood retinal barrier. Therefore, a number of pro-inflammatory agents are released, and evaluation of these will provide an insight to the ongoing retinal damage due to diabetes. The peripheral blood markers are inexpensive and easily accessible. OCT is a non-invasive imaging modality that provides structural in-depth of the retina and choroid. OCT biomarkers help in evaluation, management, and treatment response prediction in the diabetes retinopathy. The objective of our study was to determine the role of systemic inflammation in diabetic retinopathy and to investigate the correlation between OCT biomarkers and systemic immune inflammatory index in diabetic retinopathy. So this was a case control study which conducted in Tertiary Care Hospital in South India, where we included 50 eyes of diabetic patients with varying rates of retinopathy. The inclusion criteria was patients diagnosed with diabetes mellitus type 2 and no cataract surgery in the past 6 months. Exclusion was any OCTs with poor quality, any infections or fever in the past 2 weeks, any other kidney, liver or autoimmune diseases, and any use of any immunosuppressive drugs. So the patients underwent visual acuity measurements, anterior segment and dilated fundoscopy with the slit lamp biomicroscope and optical coherence tomography. The neutrophil, lymphocyte and the platelet counts were obtained from the complete blood count, and the systemic inflammatory markers were calculated. These included the neutrophil lymphocyte ratio, which was calculated by dividing the neutrophil by the lymphocyte count, the platelet lymphocyte ratio calculated by dividing platelet count by the lymphocyte count, and the systemic immune inflammation index, which was calculated by multiplying neutrophil into platelet divided by lymphocyte. The OCT biomarkers included hyperreflective foci, intraretinosis, disorganization of retinal inner layers, and subretinal fluid. Results: we had 50 eyes of 25 patients, 24 of which had no DR and 26 had DR. Among this, we had 6 mild NPDR, 9 moderate NPDR, 2 severe NPDR, and 9 PDR. The group statistics showed that among the inflammatory indices, the PLR and the SII had had higher mean in DR group than the non-DR group. However, statistically, SII was more significant, and also among the OCT biomarkers, it was found that the hyperreflective foci correlated more statistically significantly with the SII. This is the ROC curve with AUC of 0.76 for SII, and the cutoff was fixed at 608.21 with a sensitivity and specificity of 65.4% and 75% respectively. So I would like to conclude my study by saying that this study demonstrates the value of simple serum biomarker SII in predicting the risk for progression of diabetic retinopathy, and thus helps in the monitoring follow-up. Also, it can be used to evaluate the treatment response in cases of macular edema. Thank you.
Can you tell me the basis for choosing 2 weeks as the cutoff for any previous infection? Like, does it have a scientific basis based on half-life of neutrophils? Have you referred to some previously done studies?
Yes, sir. In the previously done studies, also it was taken as
but
2
why
weeks
2
because
weeks?
Raised inflammatory markers will be raised in the first 2 weeks.
No, but do they go down in 2 weeks' time? Do they go completely down in 2 weeks' time? Because we are dealing with simple neutrophil count, platelet count, and lymphocyte count. So anything which can tamper with it, we have to exclude it completely if we want to attribute everything to the risk of progression of diabetic retinopathy. Okay?
Yes.
Okay, fine. I think more studies are needed with much higher numbers for coming to any conclusion. Next, we have Dr. Sarbraj Nag. He'll be talking about an interesting case of subacute dimness of vision with not so usual suspect. Can we have, yeah.
Good afternoon, everyone. My topic is an interesting case of bilateral subacute dimness of vision with not so usual suspect. Myself, Dr. Sarbraj Nag, co-author, Dr. Bibhash Bala, Dr. Kaustubh Datta. A 27-year-old lady with chief complaint of bilateral blurring of vision for 3 to 6 months. It is subacute in onset and gradually progressive in nature, not associated with pain, redness, headache, and neck pain. There is no history of trauma, steroid intake, symptoms suggestive of diabetes, drug abuse. The patient is a diagnosed case of schizophrenia for last 3 years and an olanzapine and valproic. Visual acuity 6 by 36 both eye, best corrected visual acuity with refraction 624 both eye. Rest of the anterior segment is normal limit. On dilated fundoscopy, vertical cupping ratio 0.3:1, disc is within normal limit. Vessels are normal in caliber, AV ratio maintained. Foveal reflex dull. There is a yellowish spot in the fovea which is surrounded by a halo of pigment in both the eyes. Peripheral retina is within normal limit. Systemic examination within normal limit, except the patient was not fully cooperative. Now we ran a OCT and OCTA. Now OCTA solving the mystery. OCT macula shows bilateral hyporeflective zone at fovea suggestive of focal disruption at IS-OS junction and RPE. On probing, there is a history of sun gazing is given by the patient party, and the patient used to stare at the sun very often. So our provisional diagnosis is solar maculopathy. It referred to pathophysiologic entity causing visual disturbance sustained during or after prolonged or high intensity exposure of the foveomaculoretinal tissue. Risk factor include young age, clear lens, photosensing drugs, etc. Diagnosis done by proper history taking, fundus examination, and OCT. The differential diagnoses are primary foveomaculoretinitis, operating microscope and endoluminal injuries, laser retinopathy. Most patients recover within 3 to 6 months with a visual acuity returning to level of 6.6 to 6.12. There may be residual metamorphosia paracentral scotoma. Also, novelty in this case is a unique case as the patient is a schizophrenic. A recurrent sun exposure is associated with this case, not a single exposure in usual cases. Hence, it has not followed the natural course of the disease. Primary prevention is the mainstay of treatment done by wearing special filter goggles. My take-home message: all specially able persons should undergo comprehensive ophthalmological checkup and routine screening with OCT macula, as many of the times they are unable to keep proper history. Primary prevention of solar retinopathy should be implemented in all those specially able persons, especially who are having additional risk factors. These are my references. Thank you.
Yeah, nice presentation and a good case, because these patients often are at risk of many self-inflicted injuries. I myself reported cases where pins were inserted by the patient himself, some 60-70 pins, and he claimed that he had been kidnapped and he was injured by somebody else. So proper history taking is important. High index of suspicion is very important in such cases. Okay, thank you, Dr. Sabraj. Next, can we have Dr. Harshit Bansal? Dr. Harshit Bansal, are you there? If he's not there, can we have Dr. Niveta Vijayaraj? Yeah. Can we have the slides?
Good afternoon, sir. Good afternoon, all. A case of giant retinal tear, the road not taken. A retinal tear of more than 90-degree circumferential extent, more than 3 clock hours, is termed as a giant retinal tear. In contrast to retinal dialysis, in retinal tear, the posterior vitreous is detached. The vitreous gel is attached to the anterior flap, hence the posterior flap tends to fold over. The management of giant retinal tear is an emergency. A 40-year-old male presented to our casualty with a sutured wound over the left eye, periorbital edema, ecchymosis, and enophthalmos. The right eye vision was 6.6, the left eye was 6.12, no improvement with glass and pinhole. After a slit lamp examination, an immediate indirect ophthalmoscope examination was done in supine position. The right eye fundus appears to be normal with the disc pink, vertically oval, cup disc ratio of 0.3, vessels normal, fovea reflex present. The left eye media clear, disc appears normal. There is a giant retinal tear involving 4, 5, 6 clock hour with anterior and posterior flap. Macular fovea reflex present. The patient was taken for immediate laser retinopexy. The left eye, power of 200 millivolts, duration 200 milliseconds, and 763 confluent burns were given. After 6 months, the patient reviewed with a vision of 6.6. The fundus showed a flat attached retina posterior to the barrage marks. Discussion. Primary laser photocoagulation in treatment of giant retinal tear has become a viable alternate in the absence of significant subretinal fluid. Suspect giant retinal tear in all trauma cases with blunt trauma to the eye, especially over the brow region. Detailed inspection of the retina with indirect ophthalmoscope in supine position must be done. Follow up the patient with visual acuity and fundus examination for 6 to 18 months. Conclusion. Indirect ophthalmoscope with scleral indentation should be done for all trauma cases to rule out peripheral retinal break and dialysis. Laser retinopexy forms a viable, less invasive office procedure for giant retinal tears, avoiding major surgical intervention in such productive age group. Thank you, sir.
Can you show the slide where laser marks are fresh? Yeah, so they don't seem very confluent, okay, even though you have been able to keep the patient with an attached retina now. You can see there are gaps between the spots. So maybe you can consider additional laser in the follow-up period. Because a short-term outcome is not something we have to target. We want to make sure that this giant tear stays in that place position for the remainder of his lifetime. Okay, but a well-managed case, if it's still attached, mostly it shouldn't have an issue. But just consider some additional barrage laser marks.
Thank you, sir.
So I think we don't have two speakers. Dr. Lagna Jeeta Banerjee isn't here, and we don't have Dr. Harshit Bansal. So with that, we come to an end to this session. Thank you, everyone. The hall can be taken up by the chairperson of the next sessions. So we were running late, but I think we have finished our session in 1 hour 5 minutes as per the allotted time.